Welcome to the Erectile Dysfunction Radio Podcast. This is the podcast dedicated to educating and empowering men to address erectile dysfunction, improve confidence, and enhance the satisfaction in their relationships. This podcast is brought to you by ErectionIQ.com. Learn more at ErectionIQ.com.
Welcome to the Erectile Dysfunction Radio Podcast. I am Mark Goldberg, certified sex therapist. I am deeply passionate about working with men like you to help resolve their ED. Today we are joined by Dr. Robert Segal. Dr. Segal has been on the podcast in the past. If you haven't heard that episode about erectile dysfunction and low testosterone, I encourage you to listen to that. Dr. Segal is the treating urologist for the patient who we are in a 4-part series about. So just a reminder for listeners who heard the first episode, the patient developed erectile dysfunction and avoidance of intimacy, as well as some physiological reactions to masturbation and ejaculation. In order to address the erectile dysfunction and avoidance of intimacy, we needed to understand what was happening or causing the physical symptoms after ejaculation, which we were hypothesizing was a top driver for avoidance and interference with erections. I sent the patient to Dr. Segal to further assess these unique symptoms and for medical guidance on how to proceed with psychogenic treatment, in particular, whether this patient could safely engage in sexual activity. What we want to understand today is some of the considerations in assessing this patient's presentation. Before we jump into that, however, one of the features of this case was that the patient spent a lot of time from, I think, the first time you had seen him and referred him to therapy until he actually went ahead and made the call. So I want to know, just in your experience, how common is it that you'll refer a patient for sex therapy or mental health therapy, and they may take months or even years until they go ahead and follow through?
I think that's a great question. And in my experience, perhaps a better question would be, what proportion of patients do I send to you or other psychotherapists? So what proportion of men actually go for the referral? And I think it's actually a low number. I think there's probably a lot to do with it. I think in this day and age, people kind of want a very rapid solution. They want an easy solution. They want to take a pill and kind of be done with it. And I think that, for patients who need psychotherapy for psychogenic ED or sexual dysfunction, it's very often not a quick fix. And so I kind of warn the patient ahead of time that you have to be committed to the therapy, or else it's not going to work. If the patient firstly doesn't perceive that there's a psychogenic component to their dysfunction, then I think, frankly, it'll be a waste of time for them. They will go in with perhaps some preconceived notions about what psychotherapy is. And if they're not fully committed, they might blow it off or they might not take it seriously, and then they're not going to benefit from it. So that's kind of what I warn people, even going in when I'm making the referral, is that you need to be committed to this, or else it's not going to help you. Or if you don't think this is your problem, it's probably going to be a waste of your time. So that being said, I refer a lot of men, and they accept the referral. And then my particular practice is I want to see the patient back usually within about 3 months. Again, because for me to see them back in a week or two, they're not going to really make much progress, assuming they make the call right away. And it's not uncommon that I don't see them at the 3-month mark, and it may be 6 months or 9 months or even a year before I'm seeing them back. And then they tell me, oh, I hooked up with Dr. Goldberg and things are going well. So I would say it's not uncommon that there is a delay, or the patient comes back to see me when the medical options have failed, and then I'm resending them to you or providing your credentials again.
So Dr. Segal, this patient was seen by you about 18 months prior to him reaching out to me. At the time that you saw him, did he present with the additional symptoms of dizziness? It seems like some panic, fainting spells, or did he just mention that he was experiencing a sexual dysfunction?
When I had initially seen him, The primary complaint was erectile dysfunction related that his words, not mine, related either to his anxiety or the treatment of his anxiety. He was on certain anti-anxiety and antidepressant medications. So there was no comment about the other symptoms at that time.
And that makes sense because I think that he had not linked the two really together until a couple more incidents had taken place, I think, between the time that you initially referred him and when he actually reached out. So now, more broadly speaking, a patient is reporting a set of symptoms, in this case, dizziness, shortness of breath, fainting spells after masturbation, and other forms of sexual activity. What are some of the possible areas of exploration or explanations that come to mind?
So, this is not something that I see very commonly, and so the kind of more broad issues that I'm at least considering, could he have underlying anxiety? And in this case, the patient reported to me that he had a history of it. And I kind of defer the further evaluation of that to someone like you to try to tease out kind of what about his anxiety is triggering his sexual dysfunction and kind of what manifestations thereof result. So when I had seen him back, this was actually after having a discussion with you. And yes, it was about a year from when I had initially seen him. You had mentioned that these symptoms to me that, again, the patient had not noted himself. And it led me to think about this rare phenomenon called post-orgasmic illness syndrome, which is something that, I did know about. I had seen possibly one patient who had some of the symptoms thereof. And I've been in practice 8 years now. I did a 2-year fellowship in sexual medicine. So, I've been doing this for 10 years. So the fact that I've only seen one prior patient with this kind of highlights how rare it is. But that was also something that came to mind.
Is there any other possibility that would cross your mind other than anxiety or this, what seems like a rare post-orgasmic illness syndrome? Is there anything else to rule out?
I would say that urologically, there aren't really any other definitive tests that I could think of. Just thinking about what I have in my armamentarium, or is there certain lab work that might contribute in particular to this? I mean, certainly someone who has issues with ejaculation or orgasm, checking serum testosterone could be pertinent. With the symptoms that he was reporting, kind of dizziness, shortness of breath associated with ejaculation. I mean, I didn't think that was all that germane. Certain imaging tests, for example, evaluation of the testicles or evaluation of the urethra. I didn't think that it would really contribute much in this otherwise young, healthy male. There was nothing kind of dangerous that I was worried about. So I didn't think that there would be other tests that would be a high yield for me.
Got it. I think that's what you shared with me as we were consulting back and forth. And I was looking for that guidance in terms of whether I could proceed forward with some exposure exercises safely with the patient. Mm-hmm. Now, this patient is in his early 30s. And, what I'm gathering is what seemed the most likely culprit to you after evaluation is some underlying anxiety. Is that correct?
Absolutely. And again, just to reiterate, he had reported to me his history of anxiety. And so I knew it was there. And that certainly reinforced it for me. If I see a patient who comes in with no prior medical history, sometimes you get a sense that there's underlying anxiety just based on, how they interact with me or how they respond to questions or that sort of thing. But in this case, that was a big kind of clue for me.
In other words, you're not necessarily diagnosing anxiety, but this patient had a pre-existing diagnosis, which really indicated a strong possibility that what was happening was this underlying anxiety.
Yes. And in a similar situation, if I suspect that there's anxiety that is undiagnosed, I would typically refer the patient either to you or to their primary care provider to determine the next steps in diagnosis or treatment for that.
Dr. Segal, can we go back to this condition called post-orgasmic illness syndrome? Now, I know it's rare, but I think our listeners are going to be interested to just learn about this a little bit further. So can you describe what exactly this post-orgasmic illness is?
Sure. So this is a condition, and I reiterate there's not much known about this. If you look at in the medical literature, there are not many studies on this. There's in fact only one author who has kind of widely written on it. Other articles are more like review articles, that sort of thing. But it's basically considered or thought to be essentially an allergy to something in the ejaculate that can result in certain signs or symptoms. And these are characterized into different categories or what are called clusters. But in essence, patients can develop these symptoms at times immediately, like within seconds of ejaculation. And that's whether they're active with a partner or doing self-stimulation. Or it may take several hours to develop, and it may last several days before they abate.
So there are different presentations, and we're going to come back, I think, in a couple moments to that time delay, because that was a feature when I was working with this patient. You mentioned that this is a reaction to the ejaculate. Is there like something particular that we know of in the ejaculate that causes this type of reaction?
Again, I don't know that it's absolutely known. I know that there have been some allergy studies in men who have this condition where they're basically, like a skin allergy test, for example, is performed with the men's own sperm, and they don't react. So it's not necessarily an allergy to sperm. It's something else in the ejaculate. There's other thoughts that it might be an autoimmune disorder. Again, I'd say most of our knowledge on this condition is kind of early.
So if a man utilizes a condom, would this theoretically alleviate the problem? Is it the exposure to the ejaculate, or is there something also being set off internally before the ejaculation happens?
No, that's a good question. My understanding is that even with a condom, it would still be the risk of the resultant reaction. So yeah, I don't think it's the condom itself that would protect against the symptoms.
Okay, so how is an allergy like this treated? I know you mentioned that this is not common and this is not something that you are treating even on an annual basis. But if somebody does have this condition, how is this managed?
So, as you can imagine, that this can be a very difficult thing to manage because, people are associating these kind of very either bothersome or at times very terrible or intolerable symptoms with what's supposed to be a very pleasurable activity. So, notwithstanding the fact that men can have, bad psychological kind of responses or sequelae as a result, I think that the treatments that have been most often attempted would be anti-allergy medications such as antihistamines. There have been other treatments tried like with SSRIs or benzodiazepines. So again, these are more related to depression or anxiety or kind of psychological issues. So I think the mainstay would be anti-allergy treatments like antihistamines or possibly even corticosteroids.
Now, is it also safe to assume that this condition does not pose a threat to a person's actual health? Or is it possible that in, again, some rare subset of this population, that this allergic reaction could be dangerous?
I'm not aware of any reported cases of like anaphylaxis, for example, but certainly what one of the clusters that is associated with this could be it's broken down into what's called the throat cluster. So you can get dry mouth or coughing or sore throat or voice hoarseness. So there's no evidence necessarily of like respiratory distress as a result, but I would say it's possible to get early symptoms that could be concerning. Although, again, just to reiterate, I'm not aware that major risk to the patient is likely.
In other words, it could be felt in the throat, but you're saying you're not aware of any reports of this becoming, life-threatening.
Exactly.
Okay, so coming back to this patient, so he was reporting a delay between the time of ejaculation and the onset of symptoms, sometimes for more than 24 hours.
Mm-hmm.
He also has some specific patterns of experiencing symptoms after overexertion or masturbating multiple days in a row. Could this pattern be allergic, or does this lean way more in the direction of this being psychosomatic or anxiety driven?
I mean, to me, just based on this description, I would still favor the post-orgasmic illness syndrome. And again, if we're assuming that there is an underlying allergy component to it, then I would favor that.
In this case, was this patient encouraged, or if requiring prescription medication, I think most allergy medications are over the counter.
Mm-hmm.
Was he suggested to utilize a antihistamine or some other allergy medication?
Yes. So my recommendation at his last visit with me was to try exactly that: over-the-counter antihistamines approximately 1 hour prior to sexual activity / ejaculation, and to do that before I would plan for any more costly or more involved treatments.
And what I'm gathering is, based on some of our earlier conversation, it still was your overarching belief that a lot of this was driven psychologically, but this was a relatively safe, just in case type of intervention. Is that correct? Yes.
So I think sometimes it can be hard to tease out, what degree of contribution is from the underlying anxiety versus if there's something else going on. And so, as mentioned, I knew that there was anxiety underlying here, and I think that was a major issue, and that was the main reason why I sent him to you in the first place. But then when I heard of these other symptoms, I did feel that this rare entity, was at least plausible, and so I figured, this is the kind of thing where we don't really know much. The proposed treatment is not that risky, and so I think there's kind of a high reward, low risk type outcome. If he tries the antihistamines, for example, and he's better, great. If not, then at least we can kind of potentially rule that out as a treatment. And yes, we may consider other more involved allergy treatments, but at least we've tried it so as to try to give him some alleviation.
Got it. So it's there as a option and a potential rule out, but you're saying it's high reward, low risk for him to be utilizing this medication. Now, is this taken in advance of sexual activity, or is this taken post?
No, I recommended it for him to take it prior to ejaculation, because, and I even said up to an hour before, because you would, in theory, want the medication on board at the time of the exposure. And so I just feared that if he took it after, then yes, it may curtail some of the symptoms, but it was my feeling that if he takes it before, that's kind of maximizing the potential treatment effect.
And I think that the patient also can benefit, or in this situation benefits from knowing that they have the medication already in them to help reduce some of the anxiety, certainly when it comes to the avoidance, because if in fact it is allergic, they now can more comfortably go ahead and break that avoidance cycle and take those risks, knowing that there is already an antihistamine in their system to help reduce, if not eliminate, those symptoms. I think it serves multiple purposes for this patient.
Yes, I agree. Obviously, when I prescribe something, I'm thinking about the potential benefit urologically, maybe I should consider more of the psychological impact of the treatments I'm providing. And it may even go without saying that a patient who, is bothered by whatever problem they have, giving them the treatment not only potentially treats the issue, but it may help alleviate some of the underlying anxiety associated with the issue. So that's 100%. I totally agree with that.
And I agree that I think that applies far more broadly than just in the case of post-orgasmic illness or a potential allergy. Certainly in other areas of or in other treatment avenues of sexual dysfunction, I think that also holds true, that when a person knows that they have something to empower them, it also helps to reduce the anxiety, break an avoidance cycle, and help them to move forward both medically, physically, and psychologically. So, Dr. Segal, if we were going to summarize your findings with this patient and where you would, I guess, either tell me it's safe or tell me what to avoid, how would you kind of just summarize that for us?
So, I mean, from my perspective, I don't view any, intervention that you propose to be harmful, frankly. So I would have no reservation about you doing, whatever you wanted to do in terms of exposure therapy, because again, I think, unfortunately, what I tell some of my patients, and I'm a surgeon, right? So I'd say this definitely holds true for what I do: no pain, no gain, right? So I'm kind of purposely injuring the patient or harming the patient in order to, for the greater good, so that they benefit long term. So I could see how that could apply here. The patient unfortunately may have to step out of his comfort zone a little bit, so to speak, in order to kind of grapple with these issues. But in the long run, hopefully he can break through and he'll be the better for it.
Yeah, and your findings, though, were that it was safe to go ahead and engage in those challenging exposure exercises, even if it did elicit some of these symptoms or potential allergic reaction. There was nothing from your findings that indicated a medical reason to avoid or to reduce sexual activity, correct?
Sir, that is absolutely correct. And I think, look, we have the evidence that, the patient has presented with these symptoms. So he's already had the adverse effects of what he's experiencing with ejaculation. And, understandably, they're uncomfortable and he wants to avoid them. But they haven't resulted in any long-term harm thus far. So that there would be no reason to be worried or suspect that he would have any worse reaction to a subsequent ejaculation.
With your medical guidance, we were able to proceed forward with exposure and treatment, and we will talk more about that in an episode in the coming weeks, where we will summarize how treatment proceeded forward and what the results were. Dr. Segal, thank you very much for joining us on this episode. I think this is very informative to our listeners.
All right. Well, thank you again very much.
If you listen to this podcast regularly, you know there is a huge mental component that goes into achieving an erection. Mark Goldberg, the certified sex therapist who hosts this podcast, felt as though this was a very underserved topic of education in men's health. That's why he designed Beyond the Little Blue Pill, the thinking man's guide to addressing ED. The course is designed to educate and fundamentally help you change the way you think about erections. Check it out at erectioniq.com/course. You can explore 3 modules of this course completely free. See if there's something in there that can help you. erectioniq.com/course, and you can learn more there.
Thanks for listening to the Erectile Dysfunction radio podcast. For more information on today's topic and understanding how the mind impacts erectile dysfunction, please visit erectioniq.com.